ventilation. Mechanisms of ventilation. So when you say, oh, before I forget, do not touch anything. That's what the technician said. Do not touch anything. Meaning you do not touch the control panels for anything in this room. Do not control the aircon, do not, except power, even the lights, just don't touch them. Aye. Yeah, like I said last time, make sure safety first. Aye. Keep yourself safe. Do not give anyone a reason to point at a finger at you. Because people have this tendency, when something goes wrong, they like pointing at students because it's easier to say, oh, the students did this. So just keep yourself safe. Do not touch anything. Right? Except sitting on the chair. That's all right. That's allowed. All right. So we're saying that we're talking about mechanisms of ventilation. When we say mechanisms of ventilation, we are talking about the way in which air goes in and out of the lungs. So yesterday we said air will go into the lungs if we reduce the pressure inside the chest. And then we talked about different ways in which the body reduces the pressure inside the chest. We said number one, there's something called a bucket handle theory. Bucket handle theory, it says that when the ribs are moved upwards and outwards, the volume, the transverse diameter increases, and this increase will allow an increase in the volume, and when we increase the volume, the pressure reduces. Number two, we talked about a pump handle theory, which states that when the sternum has been pulled upwards and outwards, it increases the anterior posterior diameter, and an increase in anterior posterior diameter allows an increase in the volume, and increase in the volume causes reduced pressure. We also talked about the diaphragm. We said the diaphragm will contract and flatten so that the horizontal diameter, the vertical diameter is increased, and therefore increasing the volume and therefore reducing the pressure. This allows air to flow into the lungs. Then we said that energy is used during normal inspiration. This energy that is used is for contraction of the diaphragm and for contraction of the external intercostal muscles. This is what we use for normal inspiration. However, if for one reason or another you are asked to breathe in with a lot of force, we gave an example of people with a disease called pneumonia. They find it very difficult to breathe normally. So what they do is that they use what are known as accessory muscles of breathing. So we said there are accessory muscles of inspiration. These are mostly muscles of the neck, like sternocleidomastoid and scalene and serratus anterior. These muscles, they help to lift up the rib cage when the diaphragm and the intercostal muscles are not doing enough job. We also mentioned that during expiration, breathing out, normal breathing out does not use energy. This is because relaxation of the diaphragm and relaxation of the external intercostal muscles, it allows the volume to reduce. When the volume reduces, the pressure increases. When the pressure increases, air is pushed out from the lungs. So this is a passive process. However, if for one reason or another you fail to breathe out normally, the body will use other muscles to help you breathe out. And these are the internal intercostal muscles and the abdominal muscles. Have you learned about abdominal muscles? You've learned about the six-pack, yes? The muscle that makes the six-pack is called the... There is a muscle called rectus abdominis. It is the one responsible for making a six-pack. You have other muscles like transversus abdominis. You have other muscles like external oblique, internal oblique. You learn about these things. But all we are saying is that these are muscles that the body will use to help us push air out when you have a problem. It is also something that you should know. There is something called paradoxical breathing. Paradoxical breathing is when the abdomen does the opposite of what it's supposed to do normally. In a normal person, when you breathe in, the diaphragm pushes your abdomen downwards, so we expect the muscles of the abdomen to be relaxed. And then when you breathe out, the diaphragm pushes up, and you expect your abdominal muscles to contract. However, when there is paradoxical breathing, the abdomen lifts up when you are supposed to breathe out, and it flattens when you're supposed to breathe in. You understand? Huh? Basically, the abdomen does the opposite of what it's supposed to do. So when you breathe in, take a deep breath. Your abdomen flattens, yes? When you breathe out, you can feel your abdomen filling up. So paradoxical breathing is the other way. When you breathe in, the abdomen becomes big. When you breathe out, the abdomen flattens. It's called paradoxical breathing. It means instead of breathing in using your intercostal your accessory muscles of breathing, you are breathing in using abdominal muscles. And that is a problem, a very, very big problem. You will see this when you start working, especially in children. It's common in children. Okay, then moving on. So we've learned about mechanisms of ventilation and also what we call accessory muscles of breathing. So we mentioned that when you are breathing in, there is use of energy. This use of energy, because there is movement of muscles. At the end of the day, we are saying when you are breathing in, the body carries out work. In other words, there is what is called work of breathing. So, when you are doing this work of breathing, the airway, number one, the body has to bring in that air and pull it against the airway resistance. So we call that resistance, work against airway resistance. Number two, when you are sucking in that air, the muscles have to do work to allow the lungs to expand. This is called work against compliance. So basically, we are saying the work of breathing has different parts. One part is to allow the air to pass through the passages. This is called work against the airway resistance. And the other part is to allow air to fill in the lungs so that they expand. This is called work of breathing against compliance. Okay, so basically, we're in one of the exam questions when we ask you to say write short notes about work of breathing. We expect you to categorize to say, oh, in work of breathing, there's work of breathing for expanding the lung, there's work of breathing for airway resistance, and there's work of breathing for the chest wall to make the chest wall expand. There is also work of breathing. However, in normal expiration, there is no work of breathing. Have you guys learned about laws of thermodynamics? Yes? You remember those things? In Ganong, there is a diagram, a very weird diagram, on work of breathing and how to calculate work of breathing. You remember those things like isovolumetry and isobaric and the equation for which one? You remember that? You don't remember the equation? Laws of thermodynamics. So at the third law, to work towards entropy. It's second law, right? All right. Anyways, we won't ask you to calculate. However, I'm just informing you so that when you go read, you see a Cafani curve, you should understand that work of breathing is calculated using laws of thermodynamics. We don't expect you to use them. We just want you to be aware. Just be aware that we use laws of thermodynamics to calculate this work of breathing. And like we said, it's in three parts: to expand the chest wall, to expand the lungs, and to overcome airway resistance in the tracheobronchial tree. Okay? All right. Then, coming back now, we need to talk about pressures. Yes? We said that when you are breathing in the air, the chest has to reduce the pressure. So the question is, this pressure we are reducing, what is it? So we have three types of pressures inside the chest. Number one type of pressure is called intrapulmonary pressure. This is the pressure found inside the alveolus. So this pressure is caused by air which sits inside the air sac. This is called intrapulmonary pressure. So this intrapulmonary pressure, you should know that when the air is filled, when the air sacs have been filled with air, the intrapulmonary pressure increases. When the air sacs have no air inside, intrapulmonary pressure reduces. In the textbook, they will tell you that intrapulmonary pressure changes between -1 and +1. You remember in mathematics, we drew something called a sine curve. You remember the sine curve, right? And it was always between +1 and -1. Unless you do sine chan plus 1 and sine chan plus 2. You remember those things? Yeah? All right. So basically we are saying our intrapulmonary pressure has a sine curve, right? Between +1 and -1. So when you are breathing in, the air goes into the air sac and the pressure goes up to +1. When you breathe out, the air will go down and then it will reach as low as -1. Why do you want to reach -1? Because when you reach -1, you are telling us that the air inside the lung, the pressure inside the lung is less than the pressure outside. This allows air to go back in. If the air pressure was going back to 0, it would mean that this is the pressure that is equal to the atmospheric pressure. Then there will be no flow of air. You understand what I'm trying to say, right? When we say -1, we are saying it is -1 less than the atmospheric pressure. Therefore, air can come from outside and go inside. It's from low pressure to high pressure. If we say the air, the intrapulmonary pressure is +1, we are saying it is 1 millimeter higher than the atmospheric pressure. Because it is higher, air will come from the lungs and go outside. You understand, huh? All right, that is the intrapulmonary pressure. Then there is what is known as transpleural pressure. Intrapleural pressure. This is the pressure that is found in the pleural cavity. So the pressure found in the pleural cavity is always negative. It ranges from -2 to -6. When you are breathing in, it drops to -6. When you are breathing out, it increases to -2. It's always negative. Why is this? Where does this pressure come from? Number one, it comes from the fact that you remember we said there is a membrane that is attached to the lungs. It is called a visceral pleura, yes? And there is a membrane that is attached to the chest wall. It is called a parietal pleura, yes? And in between there is a space that is covered by a fluid called pleural fluid. This pleural fluid is produced by the visceral pleura. This pleural fluid is important because it nourishes, it gives food to the pleural cavity itself. So we cannot completely have no fluid there. We also cannot have too much fluid there. If you have too much fluid, it's pleural effusion. You get a pleural effusion, yes. Okay? If you have too much fluid, out so that it does not accumulate inside the pleural cavity. The normal amount of pleural fluid, it keeps circulating. It is there, then it is removed so that the new fluid comes and then it is removed and then the new fluid again. So this that allows
so sensitive.
this
Okay, try to put
of
some
pleural fluid is the one that produces intrapleural pressure is caused by the sucking in of pleural fluid from the pleural cavity. Then we also have this thing called a chest wall. I don't know how many of you have cut a chicken before, but if you cut a chicken on the chest, you just hit it back, you will notice that what do the ribs do? They do like this. Have you ever noticed that? When you cut the chest wall of a chicken in the middle, the ribs just go. It's almost as if the chest always wants to open. And you have to remember this all the time. The importance of having a sternum here is that the ribs are not relaxed. They are always pulling outwards. They want to relax. But they are held to the sternum. The moment you remove the sternum, the ribs will go all the way back. So in other words, we are saying the chest wall has a tendency to open up. It is pulling itself outwards all the time, naturally. And that pulling is also responsible for causing intrapleural pressure. So basically we are saying intrapleural pressure comes from two main causes. One, the sucking of pleural fluid from the pleural cavity, and number two, the tendency of the chest wall to pull outward. This causes a negative pressure inside the chest wall. Then we want you to know that this pressure is very, very important because it allows the lungs to open. If the intrapleural pressure was positive, the lungs would not open up. it will be very difficult for the lungs to open. So the sucking pressure or the negative pressure, it is sucking the lungs, basically it's widening the space in the lungs. This allows the lungs to open. It is stretching out the lungs so that they can open when air moves in. Okay? So basically we are trying to tell you intrapleural pressure is important for opening up the lungs. Assuming this intrapleural pressure wasn't there, what would happen basically is your lungs would lose their air, and once they close, that's it. You won't be able to breathe anymore, which will be very difficult for our living bodies. Okay? All right, so that's intrapleural pressure. The difference between we say there's transpulmonary pressure, which is found inside the alveoli, and then you have intrapleural pressure found inside the pleural cavity. The difference between these two is also called, so intrapleural pressure, and the difference is the transpulmonary pressure. I hope that makes sense. Yes? There is interpulmonary pressure, intrapulmonary pressure. This is pressure inside the alveolus. There is intrapleural pressure, pressure inside the pleural cavity. The difference between the two is called the transpulmonary pressure.
Okay.
Intrapulmonary, meaning inside the alveoli. Intrapleural, inside the pleural cavity. And the difference is called the transpulmonary. And then we mentioned that intrapulmonary, the one inside the alveolus, is between +1 and -1. And this we mentioned also that intrapleural is between -2 and -6, and the difference between the two basically will become the largest being a 5 and the lowest being, actually it goes all the way -1 and -6, the difference being somewhere around -5, isn't it? And then between +1 and -2, the difference generally being something like a 2. You understand? Huh? All right. The 3, yes? Between +1 and -2, the difference is 3, isn't it? Yes. So basically, we're saying transpulmonary pressure ranges between 3 and 5, somewhere there, 3 to 5, depending on whether when you breathe out, the pressure is around 3 because there is high pressure trying to force air out, and then the pressure goes to around 5 when you're breathing in. You understand, huh? Not making sense. Don't worry. It will make sense when you look at the diagram.
In which unit is the pressure measured?
Sorry?
In which unit is the pressure measured?
The unit in which the pressure is measured is millimeter, but however, when we tell you so, what
millimeter
I
of
was
mercury.
saying was that we are going to say +1 and -1, not because this is the unit we are measuring. We say +1 and -1 because it is the pressure compared to atmospheric pressure. It is +1 more than atmospheric pressure. Not that we are saying it's +1 millimeter Mg.
Okay.
Yes, it is +1 more than the atmospheric pressure, and it will be +2. When we say -2, we are saying it is -2 less than atmospheric pressure. Atmospheric pressure is on average is around 760. So if we say -2, we are saying 760 -2. If we say +1, we are saying, okay, 760 +1. You understand? Huh?
Yes.
All right. Basically, so like I said, the pulmonary pressure is inside the alveolus, and then you have pleural pressure inside the pleural cavity, and the difference between the two called transpulmonary pressure. And we say the largest difference between these is seen when you are breathing in, which means you see that one is -1 and the other one will become -6. That's when you see the largest difference, and that's when the air is sucked in. And then when you see a small difference between the two, you will realize that the pressure allows the air to go out of the lungs. Okay? So basically we are saying if we increase the difference between pleural and pulmonary pressure, we allow air to be sucked into the lungs. If the difference between them is smaller, air is pushed outside the lungs. Anyways, it will make sense when you read through. All right. Then we said that this transpulmonary pressure is important to keep the lungs open. So we have to remember that the lungs have elastic tissue. You remember when you are learning about connective tissue, they told you that there is what type of tissue in the lungs? What type of connective tissue is in the lungs? They didn't mention anything about reticular. They mentioned something about the tissue, right? And then they told you that there is elastic fibers, yes? So, the tendency of elastic fibers is that when you stretch an elastic, what does it do? It wants to go back to normal. It wants to retain, it's called what? Recoil, yes? You learned in physics about the spring, yes? About the recoil of a spring, you learned those things, yes? So basically we are saying, we are going to apply the same principle in. Like I said, we don't need to do calculation. But just remember that when you stretch something that is elastic, it has a tendency to recoil. Proportionality has been reached. You remember those things, yes? All right. So in our normal lungs, which have not yet reached a limit of proportionality. So when we breathe in, they stretch. And what is the response of something that stretches? Collapses. So in other words, we are telling you that the lung likes to collapse. It prefers to be in a collapsed state. This is called atelectasis. You remember atelectasis? A collapsed lung. When the alveolus collapses, it's called atelectasis. So we are saying the lungs prefer to be in a collapsed state because they are made of an elastic. It's called elastic recoil. So how do we prevent that elastic nature from closing our alveoli? Simple. Intrapleural pressure. We explained that the pressure, the negative pressure inside the pleural cavity, it stretches, keeps the lungs stretched. You remember, huh? This is the reason we don't need to have too much fluid in the pleural cavity. Number two, we said that the chest wall also tends to pull against it's pulling away from the chest. And this also has to be maintained because at the end of the day, if your chest wall pulls too much, then it means that your lungs won't receive enough pressure. So how do you prevent the chest wall from going all the way? We have an intrapleural pressure that tries to pull the opposite direction. So, in short, we are saying lungs like to collapse, and the body has mechanisms that prevent lungs from collapsing. However, intrapleural pressure is not enough to prevent lungs from collapsing? Because the lungs also have something called tissue fluid. You remember tissue fluid, yes? In grade 12, you remember in grade 12, biology, they told you that there are blood vessels, capillaries, yes? And you even drew capillaries. And you also drew that there is something called hydrostatic pressure, yes? The pressure of blood in the blood vessel. And you also learned that when it reaches the tissue, what does it do? It starts
Spills out.
leaking out. You remember that, yes? And when it leaks out, it bursts the cells in the tissue. And this is called tissue fluid, yes? So we are trying to tell you that the lungs have tissue fluid. And this tissue fluid is surrounding the alveolus. And this tissue fluid is, if you remember in blood, you learned that fluid from the blood is 90% water. Yes?
Mhm.
And if you remember in first year, you learned there's something called surface tension. Yes? And you learned that water has a high surface tension. Yes? This is the reason you have animals that can walk on water. Because water has high tension. You learned that, yes? All right, so this is the reason why insects can walk on top of water, because water has high surface tension. In short, we are saying the lungs are surrounded by a water that has high tension. And this high tension, maybe before we go very fast, when you say surface tension of water, what does it mean? Because we might be agreeing you don't know. Right? What do you think it is about? What does surface tension mean? What does it say water has high surface tension? What does that mean? Exactly. Water molecules have a tendency of sticking to each other. This, you also learned that because of surface tension, water is able to pour. Yes? You learned that, yes? That if I if I have a glass of water and I tilt the glass of water, water moves almost together like a stream. It's like when one drop goes, the other ones want to fall. They have a tendency of sticking together, isn't it? It's not, and also you also learn that water is able to make droplets because of surface tension. Yes? Like when one water is on one side, the other one want to stick together so that they make a ball. They want to stick to each other and keep the air out. You didn't learn that? Anyway, long story short, the lungs are surrounded by water which has high surface tension. This high surface tension makes water want to stick together, which tells us that other than the elastic recoil, the tissue fluid in the lungs also wants the lungs to collapse. You understand, huh? Because the water on one side of the alveolus and the water on the other side of the
Pulling
alveolus,
each other
they want to
forwards.
stick together. And if they stick together, the space in between where you have the alveolus, it will collapse. You understand, yes? So how do we prevent this water from making our lungs to collapse? Because we cannot say there should not be water in the lungs. We need that water to feed the lungs, yes? We need tissue fluid so that the lungs can be cleaned from carbon dioxide and other waste products. You remember the importance of tissue fluid. We need the tissue fluid to be there. However, when it is there, it is causing the lungs to collapse. How do you prevent that? Very simple. God, in His infinite wisdom, if you don't believe in God, my friend, you should start now. Because God, in his infinite wisdom, he produced something called surfactant. He made a fluid inside the lung, which is called surfactant. You remember surfactant, right?
Yes.
We say that the alveolus and the bronchioles, the respiratory bronchioles, they have a cell which is called a pneumocyte type 2. And they also have cells which are called Clara cells. And these cells produce a liquid that is called surfactant. And this surfactant is spread throughout the lung. What is the importance of this fluid? It prevents surface tension. It reduces the surface tension in the lungs. I'm fine. Yes. Something like that. Yes. Duty call. They are calling me. There's a patient for C-section, so I have to go and do a cesarean section. We can call it a day.
Yep.
Wait. All right. So, I told them I'm not around, so we'll wait. They'll call back if there's someone. They don't find anyone, then we'll call it a day. All right. So we're saying there is a fluid called surfactant, and surfactant, the reason the body produces surfactant is to reduce the surface tension inside the lungs. It's important to remember that surface tension inside the lungs follows a rule which is called the law of Laplace. So the law of Laplace says that when the alveolus has a small radius, it requires a higher pressure. It has higher surface tension when it is a small radius. Which means that when you breathe out, there is the increased surface tension. And when you increase the surface tension by breathing out, it means your lungs are likely to collapse every time you breathe out. So to prevent that from happening, the surfactant neutralizes or reduces it. So how does the surfactant reduce surface tension? Very simple. Surfactant is made up of phospholipids. Phospholipids are amphipathic. You remember amphipathic, yes?
Yes.
In other words, they create what are known as micelle-like droplets. And this allows or this prevents the water in one area from attracting water on the other area. Because the water in one area will be surrounded by phospholipids, the water in another area will be surrounded by phospholipids, and phospholipids from one side and phospholipids from the other side do not really like mixing. Therefore, we reduce the tendency of water to attract each other simply by forming micelle-like droplets. Okay? Surfactant also does other jobs other than reducing surface tension. Number one, it allows the baby to cry. If the baby is born and it takes its first breath inside and there is no surfactant, then the baby will not be able to breathe and the baby will not cry. In other words, we are saying surfactant allows the inflation of the lungs at birth. Without surfactant, you are going to have a disease that is known as the acute respiratory distress syndrome, ARDS. In UTH, there is surfactant. We have surfactant as a solution, as medicine. So when a baby is born prematurely, it means that they do not have enough surfactant for their lungs, we give them our own surfactant. We start giving them surfactant, IV. And luckily, a few of them they survive, a few of them they don't manage, but we do what we can. Okay? So from today onwards, we want you to remember that a child that is born prematurely has not yet reached a level of producing enough surfactant. Therefore, this child will need to be put on an incubator, or you can give them surfactant as an injection. Also, you will learn that surfactant increases when you are stressed. This is the reason we encourage labor. When a woman is in pain, she's screaming everywhere, you are encouraging a push, push, push. What is the body doing? Producing surfactant. And at the end of the day, the baby is born, it cries. We are happy. This is the reason why babies that are born, I'm not saying if you're born by Caesar, you are bad. But we encourage normal labor compared to cesarean section because of that stressor produces surfactant. Okay? The other thing we're going to learn about surfactant is that it contains what are known as surfactant proteins. There are surfactant protein A, surfactant protein B, surfactant protein C, surfactant protein D. SPA and SPD are useful for lung defense mechanism. You've done complement system, yes? So when I say surfactant proteins are part of the complement system, you understand what I'm saying, yes? And you've learned about a Mach complex, yes? In the complement system. And you also learned about opsonization, yes? So when I say surfactant S protein B, D is important for opsonization. You understand what that means, yes? I'm going to assume that you know. All right. Opsonization simply means if you're going to cook sima every day, you know that's what they say when you get married, it's like eating beef the same piece of beef every day, which is okay. All you have to do is lelo, matoka, mailo, maboilina, the other day you put chili, garlic spice. The other day you come, oh, let me try Portuguese, let me try chicken barbecue. But it's the same meat. It's okay. Just spice it differently every day. Today no tomato, the other day tomato. Just like that. Simple. Hey. The day that you will be like, Nieseko beef leaf. Yeah, problem. However, long story short, opsonization simply means making it look nice. Right? It means that you have what are known as macrophages, and macrophages, when you make the bacteria look nice for macrophages to engulf, that's opsonization. That's simply what it means. To make it look delicious for phagocytosis. But don't write that in the exam. I'm sure when you go Google, you find nice words. Right. But in simple terms, that's what it means. All right, so we are simply saying surfactant proteins are used for opsonization. This helps in bacteria defense against bacteria. All right, moving on. So we've talked about surfactant. So we say that surfactant reduces the chances of your lungs collapsing. Why is this important? It increases the chances of your lungs expanding. And this is called what? lung compliance. So there is lung compliance, there is chest compliance. Lung compliance simply means the lungs will increase in volume when you breathe in. When you take in your breath, the lungs will expand. That's lung compliance. If we say you have a high lung compliance, it means that when you take a small breath, a large volume of air can be accommodated. A small change in pressure causes a large volume of lung expansion. That's called the high compliance. If we say there is low compliance, we are saying a large change causes a small volume. Hope you understand. So, what are the things that will change this lung compliance? We've already said, number one, the elastic nature of the lungs. If the lungs are not elastic anymore, it means that it will be difficult for the lungs to stretch. So therefore we are saying, if there is something called fibrosis of the lungs, we are going to reduce the amount of elasticity in the lung, and therefore the lungs won't stretch, and therefore compliance will reduce. You understand? Huh? In short, lung fibrosis reduces lung compliance. Number two, we said that we have this thing called the surface tension, which is caused by fluid in the lung, which causes the collapse of the lung. So if we increase the amount of fluid in the lung, we are going to reduce the chances of the lung expanding. In short, pulmonary edema. There's something called pulmonary edema. It reduces the lung compliance. If you have too much fluid in the lung, it's called pulmonary edema. It reduces lung compliance. The other things that can check, we also mentioned that there is something called chest wall compliance. It means the chest wall has to expand for the lungs to be able to expand also. So in other words, if the chest wall is not expanding, then the lungs will also not expand. They'll have no space to expand too. Therefore, if there is something that is going to affect the chest wall expansion, it will also affect the lung compliance. For example, big chubby people like myself, because we are so chubby, our space in the lung is smaller. So the chances of the lung expanding very much are lower. In other words, we are saying obesity reduces lung compliance. It reduces chest wall compliance, which reduces lung compliance. Number two, diseases of the chest wall. For example, if the muscles on the chest wall are paralyzed, it means that your chest wall will not expand, which means that your lungs have nowhere to expand to. So, paralysis or neuromuscular disease in the muscles is going to affect chest wall compliance, which will affect lung compliance. We understand, huh? Okay, so basically that's what lung compliance is. In the exam, if I were to set your exam, in case I set your exam, I will ask you to say, write short notes about lung compliance. And all you have to do is give us the definition. It simply means the change in volume with the change in pressure. If high lung compliance means a large volume changes with the small pressure. If we say you have low lung compliance, we are saying you need a high pressure to be able to change a small volume. And then we've mentioned the factors that can affect lung compliance. Number one, anything that causes increased pulmonary fluid, like pulmonary edema, or even pulmonary congestion, even these other things called pulmonary effusion, they can reduce lung compliance. And then anything that affects the elasticity of the lung, such as pulmonary fibrosis, can reduce the expansion of the lung. Okay? So, after we talk about the expansion of the lung, we've already talked about way of breathing. Now we need to talk about the air. Yellow. You can get me, huh? Okay, let me see. I'm tired. All right. So, the last thing we want to talk about today is alright, so we're going to talk about way of breathing, the types of way of breathing, we mentioned this. Alright. And alright, the things that would increase way of breathing. Then the last thing we want to talk about, lung volumes. I think I need to show you because if you don't see it, alright. So the last thing we'll talk about today, lung volumes. So I want to talk about the volume of air that we breathe in. Number one, the volume or the amount of air that we breathe in naturally or normally, when you're just breathing normally. We call that tidal volume, which is the VT in this diagram. So tidal volume is about 500 mils, which tells us that every time you are seated, relaxing, you breathe in 500 mils of air and you breathe out 500 mils of air. Number two, I want you to know that when you take a deep breath inside, for example, you start yawning. If you take a deep breath, the amount of air that you breathe in, other than the 500 mils, in other words, in excess of the 500 mils, the extra air that you breathe in when you take a deep breath is called the Inspiratory Reserve Volume, IRV. And this is about roughly 3,000 liters, 3,000 mils, which is 3 liters. And then, if you take a deep breath out, if you breathe out forcefully, the amount of air that you breathe out in excess of the normal 500, the extra air, that is called expiratory reserve volume. You understand? Huh? Then even when you're breathing in and breathing out, even if you force all the air out and you blow as much as you can, there is a certain amount of air which never leaves the lung. This is called the residue volume. This residue volume is important because it keeps the lungs open. And remember we said the lungs should not collapse. If they collapse, they won't open for you to have more air. So we have what is known as residue volume. Depending on the book you read, residue volume is around 1,200. Expiratory reserve volume is around 1,200, depending on the book you read. Different books have different numbers. Okay? Then you have these things which are called capacities. So a capacity simply means we add up reserve volumes. For example, if we add the inspiratory reserve volume and the vital volume, the tidal volume, we add those two volumes, you end up with what is known as the inspiratory capacity. And this capacity is around approximately, like I said, depending on the book you read, right? Some people say 3,000, other people put it at 4,000. Inspiratory capacity simply means the inspiratory reserve volume plus the tidal volume. Then you can add to say the amount of air that you breathe out after forcibly breathing in. We call that vital capacity. Right. So vital capacity is simply the inspiratory reserve plus the tidal volume plus the expiratory reserve. If we add all those, it will give us the amount of air that you are going to breathe in and then breathe out again after a forceful breath. You understand? Huh? That's vital capacity. And then you have what is called the total lung capacity. It simply means the maximum amount of air that can be in the lungs. And this is called total, and it's approximately around 6 liters. Depending on the book you read, some books will end at 5.5, other books will end at 5.8. So how did we come up with these numbers? Simple. There is a machine that is called a spirometer. So what did we do? We got this thing called a spirometer, we put it on someone's mouth, and we tell them breathe. And then the spirometer will show numbers like, when he breathed in, there was 500 mils. When he breathed out, there was 1,200 mils. Okay? Why are these things important? Because they tell us when someone is losing oxygen. They will tell us from these numbers here. Diseases, depending on the disease that you have, we'll be able to tell from these numbers here. So one of the methods that we have used to be able to tell which disease a person has is by classifying what is known as FEV1, forced expiratory volume. So if you read before I came, and even when you go read after I go, you will read that breathing out takes 3 seconds. Breathing in takes 2 seconds. It will take you 2 seconds to take in all the air. Even when you are forcefully breathing in, it will only take 2 seconds for your lung to fill up. It will take 3 seconds for your lung to empty. So the whole breathing process takes about 5 seconds. No more breathing, no more inspiration. So what we have done is we got this thing called the spirometer. We gave someone to breathe out for the 3 seconds and we started measuring. So the amount of air that you forcefully breathe out in 1 second is called FEV1. The amount of air that you breathe out in 2 seconds is called FEV2. And the amount of air that you breathe out after 3 seconds is called FEV3. Now, FEV1 is important to remember because normal FEV1 is more than 80%, depending on the book you read. It's more than 80% of the total lung capacity. So if you have this vital capacity, 4,000, according to this, 4,500 vital capacity, FEV1 is 80% of vital capacity in a normal lung. Okay? So it means that 80% of 4 liters should be breathed out in 1 second. Why is this important? There is something called an obstructive airway disease. Obstructive airway disease is a disease that prevents air from leaving the lungs. An example of an obstructive airway disease is the common asthma, the very famous asthma. Asthma is the reversible inflammation of the airway, which causes increased secretions and hypersensitivity of the airway. And this asthma, when you have what is known as an asthmatic attack, there is blockage or reduction in the sizes of the airway, and that blockage prevents air from coming out. Air can go in without a problem, but air will not come out when it has gone in. And therefore, when someone is breathing in asthma, they you've heard that before, yes? It's called wheezing. They wheeze when they breathe out. It's important for you to remember this. In asthma, the noise is made when breathing out. Why? Because there is a blockage which prevents the normal breathing out. It's important to remember that. And how do we know that? Very simple. We have measured the vital capacity, and we have found that the amount of air you breathe in forcefully is normal. That's your vital capacity. It will be normal. However, the FEV1, the amount of air you breathe out in the first 1 second, is less than 80% of the vital capacity. In other words, the FEV1 vital capacity ratio reduces in asthma. And that's how we know that this is an obstructive airway disease. Number 2 obstructive airway disease is called bronchiectasis. Bronchiectasis is the excessive production of mucus in the airway. Cystic fibrosis. Also, it is failure of your cilia to beat. You also have cardiac syndrome. If you learned about cardiac syndrome, yes?
Heard of it.
You will learn about cardiac syndrome in anatomy. You also have things like chronic bronchitis. You also have things like emphysema. In the exam, we'll ask you to describe the 3 types of emphysema. And you simply tell us that, no, Doc, this is simple, drinking water. Because emphysema simply means the abnormal dilatation of the airway, distal airway. So there are 3 types of emphysema. There is one type where the bronchioles are dilated. This is called the periacinal emphysema. And then you have the other one where the alveoli are dilated. This is called panacinal emphysema. And then you have paraseptal emphysema where the airway ducts, the alveoli ducts are dilated. Simple. Aye. You understand, yes? You remember, yes? And then if a patient has emphysema and chronic bronchitis, we call it COPD. Very simple. It is called chronic obstructive pulmonary disease. And this chronic obstructive pulmonary disease is very common among patients who smoke a lot. Even people who work in the charcoal burners, and people who work in a textile factory, like a few textiles and all those other things. If they come, they are failing to breathe properly, they will obviously begin with chima fasa. Then you just know obstructive airway disease. Yes? And the way to know to prove it, you just do your FEV1 and it will be less than 80% of the vital capacity. So we have another disease called restrictive airway disease, such as lung fibrosis. This restrictive airway disease, like the name says, it restricts or prevents the lungs from expanding. And this airway disease that prevents lungs from expanding, it simply tells us that the lungs will not receive enough air inside. If the lungs do not receive enough air inside, then it tells us that the vital capacity will reduce. So in restrictive airway disease, everything else is normal. The only problem is the total amount of air breathed in has reduced. We have a reduced vital capacity. And that's how we know that, okay, this patient has a restrictive airway disease. Okay. There is another thing that you have to remember, which is called peak expiratory flow rate. PEFR. Peak expiratory flow rate. This simply tells us the speed of air when you are breathing out forcefully. Normally, it depends on it. It varies with different people. It will vary with your age. It will vary with your height. It will vary with your obesity or whether you are lean. It changes for different people. So we don't have an exact number. However, PEFR is important in assessing for asthma. If a patient has a high risk for asthma or a very severe asthmatic attack, the PEFR will be high. And if a patient has a low or a mild type of asthma, then the PEFR will also be lower. So basically, I was trying to tell you that the speed of breathing out can tell us the severity of an obstructive airway disease. It will tell us whether this is a severe obstructive airway disease or this is a mild obstructive airway disease, simply by measuring the speed at which the air is being breathed out. We get, okay? Then the other thing that we measure is what are known as ABGs. You've heard of ABGs, yes? Arterial blood gases. Anyways, we'll come and talk about arterial blood gases later. But we just want you to remember that from this measurement, we can also measure these things called ABGs. And they will tell us what disease, what kind of disease a patient has. Then, the other thing that you can measure, I hope I put it here. The other thing that we'd like you to measure is something called dead space. Dead space is the volume of air that we do not use for gaseous exchange. So there is a volume of air when we breathe into the lungs, it goes to the lungs and it is involved in the gaseous exchange. And then there's a volume of air, even if it is inside the lung, it is not used for gaseous exchange. It just goes in and comes out exactly the same way as some people in this room. Yes? You come in, you sit for 2 hours, you walk out. You be like, okay, I just wasted my time. You have slept. Right? So, I forgot. I was telling you a story about Udin. Forgot. So, we said that there was a man called Udin. There was a beautiful woman in the village, and everyone was running away. And Udini decided, as if, but let me try my luck. He tried his luck, and the woman accepted. And they started dating and started seeing each other. And then Udini had that problem that all men have. You know the problem that all men have. I don't know about women because I'm not a woman. But I'm a guy, so I know it. Because I have it also. You know that problem? Where you see this girl, she's nice. And that's what you're thinking, okay, this girl is nice. This girl is nice. Then you talk to her. 2-3 days down the line, you'll be like, my friend, this is not what I saw. You start looking somewhere else, you'll be like, oh, there's another nice girl there. Let me try my luck. Hey, guys have that problem. Some of us, we try by all means, say, okay, I've already said yes. Manje, yeah. But there are those who like, okay, I've said yes this side, but when there's no ring, there's no shine, yes? As long as you haven't put a ring on it, it's okay, you can walk away. And that's what most people think. And so this Udini had that idea, like, oh, you know what? I haven't married this woman. Let me try my luck somewhere else. Went and he tried his luck somewhere else. And then Udini discovered something weird about this woman. That she's not a woman to mess with. Right? Have you heard of Kelly Kumar in South Africa? Not a woman to mess with. This guy, what was his name again? This guy, famous footballer, decided, let me do a one-night stand. Got Kelly Kumalo, did his one-night stand, and his life never became the same again. Today, he's 6 feet under. And then there was this other guy called Jub Jub. You've heard of Jub Jub in South Africa? You haven't heard of Jub Jub in South Africa? Jub Jub was known, although he was a famous musician, but we don't know him for the music. No, we know him because he decided to do a one-night stand with Kerry Kumar. What happened to him the following week? He was in a Ferrari, and the Ferrari spun 36 times. 36 times. It went pa, pa, pa. And you know the funny thing is, these people realize that Jub Jub has medicine. So even if the Ferrari spins 36 times, he's fine. Not even a scratch on him. So the people who lowered him, the people who did whatever, realized this guy is not dying inside. So what did they do? They turned the car. I don't know if you've seen that video. It was on news everywhere. BBC, Shan. The car was spinning around. And then there were children on the side of the road. The car turned and started chasing the children. The children were running, like literally running. And the car is chasing them. Unfortunately for all the three of them, the car landed on all of them. And you will see, if you saw the video, you will see the road is there. And you can see that the car turned and kept spinning until it hit the children. That's when it stopped. And this guy called Jub Jub was arrested and driving. Now, someone with a car that spins 45 times and comes out without a scratch and kills 3 children. Yes, you find that very fine. So basically, we are saying some women, please, guys. So there are people not to mess with. Right? Anyway, this guy called Udini messed with this woman. And this woman told him that, you know what, my friend Udini, when you go to sleep, you will fail to breathe. And Udini laughed and was like, sat. From that day onwards, when Udini falls asleep, he chokes, he fails to breathe. He has to wake up and start breathing. If he's walking and then he forgets that he has to breathe, he chokes and he has to remember, I need to breathe. Udini was cursed with this very terrible case where he fails to, if he doesn't think about breathing, he can't breathe. He stops breathing. One day he went to this woman and said, you know what? I think enough is enough. I'm tired. I can't sleep. I can't eat, because when you're eating, you forget to breathe. Then you start eating. So he got tired. You know what? I'm tired. So I'm going to sleep in your house. No problem. Udini slept in a house, and that's how he died. And from this day onwards, we discovered there is something called Udini's case or Ondine's case. Right? And Ondine's case is real. Today, if you Google Ondine's case, everyone who has had Ondine's case, we only have, I think there are only 2 people that have survived. There is one who, every time he wants to go and sleep, they have to call a doctor. They put him on, you know those machines in hospital. Twing, twing, twing. He has to do that. Then he falls asleep. Then he wakes up. But that requires money. You need to have money. Because when he wakes up, he's fine. He's okay. When he goes to sleep and he forgets to breathe, it becomes a problem. It's called Ondine's case. Right? And it is a real medical condition. And we have seen it. And it is there in your Gano. You go read, right? It's there. You've read about it, yes? You haven't seen it? It's there in Gano. Ondine's case. So I'm telling you, not because I like the story, but because it's part of your syllabus. Right? You have to know it. All right. Anyways, dead space. So dead space is the volume of air which you breathe in, but it's not used for gas exchange. This is because, like we said last time, gas exchange occurs at the far end of the tracheobronchial tube, which is the terminal bronchioles and the alveolus. So when you breathe in, there is air in the trachea, there is air in the bronchus, there is air in your bronchioles, there is air in your mouth, there is air in the nose. All that air is just seated there. It's not doing anything. It will only do something if it reaches the respiratory bronchioles or the alveolus. So the volume of air that does not reach the alveolus, that is what we call anatomical dead space. It's called anatomical dead space. It is inside this anatomical structure which cannot allow gaseous exchange. Then you have what is known as alveolar dead space. Alveolar dead space is the volume of air which will reach the alveolus. But then the alveolus has a problem. Either it is collapsed and it cannot allow gaseous exchange, it has too much surface tension, or it has a disease like fibrosis or like pneumonia or like COVID. There is COVID inside the lungs and the air is reaching the lungs. But because of COVID, this air is not being exchanged. We call that alveolar dead space. And then we have physiological dead space, which simply means alveolar dead space and anatomical dead space. This is normal dead space. And then you have pathological dead space, which is simply a dead space caused because you have a disease or a condition that is there. Okay? So how do we measure this dead space? There is something called a single breath nitrogen test. This single breath nitrogen test is that you breathe in air normally. I'm very sorry for the diagram. It's a very poor diagram, but it's the best I could find. So you have this curve. You breathe in normal air, Now what we know is that nitrogen is not used for gas exchange. You learned about dilution method, yes? Aye. You learned about the dilution when you're doing body fluid compartments. They told you that if you're going to measure a volume inside the body, you should use a substance which is not metabolized, yes? Not excreted, yes? Not harmful. You remember those characteristics, yes? So we decided to say, you know what? We breathe in nitrogen all the time. But every time we breathe it in, we don't do anything with it. It comes out the same way 20. So in other words, we can use nitrogen to measure how much dead space you have. So what we did was, if you take a normal breath, there will be nitrogen inside the trachea, the alveolus, and everything else. Then after taking the normal breath, we pump in oxygen. That means that all the nitrogen that was in the airway will be pushed down by oxygen. After you take a deep breath of oxygen, we put a spirometer and we start measuring the amount of nitrogen that you breathe out. So that graph there that you are seeing, that's the amount of nitrogen being breathed out. And you notice that in the first half of the graph, it's just oxygen alone. There is no nitrogen. In the second half, in the slope, where it's making a slope, that's where you are breathing out oxygen together with the nitrogen. And in the last half, the upper part, where it slants, it makes a plateau. That's where you are just breathing out the nitrogen. So we are saying, when we measure this nitrogen halfway, we would know how much dead space you have inside the airway. Half of that, that's why you can see we have labeled dead space. We have measured half of that graph. The first half of that graph represents the amount of dead space. And people calculated. And after doing a calculation, some other guy who is very smart, he realized that this is a very tedious job because not everyone can measure this thing called nitrogen. We don't have spirometers in our hospitals, but we can do something called ABGs, arterial blood gases. When you do arterial blood gases, you are measuring the pressure of oxygen in the blood. We can measure the amount of oxygen in the blood, and we can measure the amount of oxygen in the alveoli. So that's how we came up with this thing called the Bohr's equation. It is also helping us to calculate how much dead space, how much air don't we, like we breathe in this air, but we don't use it for gas exchange. So we have this equation called Bohr's equation. And maybe if we want to be cruel, we will ask you. People were cruel to me. They asked us in my third year exam, they asked us to describe the nitrogen, the single breath nitrogen test for calculating dead space. So I will also be cruel if they ask me to write to prepare your exam. I will ask you simply write about dead space. And then you'll describe the different types and you tell us the two methods that we can use to measure. And we expect you to produce an equation. Yes? Very simple. Right? All right. Okay. I think for today, me, I'm tired. I don't know about you. I'm running out of breath. All right. So we can call it a day. Next time we meet, we can talk about gas exchange and regulation and hopefully finish the topic.